Before proceeding, we will head this chapter under following headings: Introduction, Epidemiology, Cause, Clinical Picture, Staging and Treatment, and Survival. So, before we start off, first we should brush up upon the gallbladder anatomy. So, the gallbladder is made up of various layers of tissue, which includes mucosa. It is an inner layer of epithelial cells, which is epithelium, and lamina propria, which is a loose connective tissue. A muscular layer, a layer of a smooth muscle. Perimuscular layer, a connective tissue that covers the muscular layer, and a serosa, the outer covering of gallbladder. Now, why this anatomy is important for us? It is important because based on this only the staging of gallbladder carcinomas are based upon. So it is an aggressive malignancy and it carries an extremely poor prognosis. The patient with us generally present with no specific symptoms when it is in the initial stages, of course. And most of the cases are usually asymptomatic and are found accidentally during cholecystectomy. But most of the patients present to us in advanced stages. And India has an highest incidence of gallbladder cancer, and it generally contributes nearly about 10% of the global gallbladder cancer burden. And within India, the incidence is highest in north, northeast, central, and eastern part of India, and whereas it is likely less common in south and west India. Gallbladder cancer in India usually affects the younger patients of around 5 to 6 decades, but in contrast to the West, where it is usually presenting in 6 to 7 decades. And it is one of the three leading cancer causes among women in North and Northeast Asia, followed by breast and cervix. So, this is a pictorial, graphical representation, geographical distribution of gallbladder cancer. So, this global map is telling us about the incidence of gallbladder cancer across the various regions. And India carries the highest incidence of gallbladder cancer, which is similar to Latin America, countries like Chile and Bolivia. Now, what are the causes of gallbladder cancer? So, chronic gallbladder inflammation is a risk factor which is commonly from gallstones or chronic infection, followed by xanthogranulomatous cholecystitis, porcine gallbladder, which constitutes nearly about 25% of total cases, choledochal cyst, fullness, primary sclerosing cholangitis, and exposure to nitrosomias. Now, there is a triad which dissects the risk factors of gallbladder cancer, which includes host, toxic environment, and due to vulnerable G. So, host like age, female, parity, age at first pregnancy, tobacco, obesity, OCP use, genetic mutation, or micronutrient deficiency. Toxic environment like exposure to Salmonella carriers, Helicobacter pylori, Helicobacter bacillus, which constitute little less of the cases. Exposure to irritants like mustard oil, red chili pepper, heavy metals like nickel, toxins, organochlorines, benzene, etc. And if there is an occupational exposure to rubber, coal, wood, or greasing agents. Vulnerable GB can be caused due to polylithiasis, porcine GB, misery syndrome, polyp, CBG stone, GB stasis. So all these factors in leads us to the gallbladder carcinoma etiology. Since generally patient present to us with advanced stages, so it presents with us with the symptoms of weight loss, or there will be abdominal pain or abdominal mass. It is most commonly associated with jaundice because it leads to an obstruction, and the jaundice decepts us the worst prognosis. early satiety, fullness, and ascites. Most common pathology which is being seen is adenocarcinoma, which is seen in 90% of the total cases. Occasionally, in rare cases, we can find squamous cell carcinoma, small cell lymphoma, and carcinoid tumors, which are very rare. Nearly about 25% shows only localized disease. 35% have a lymph nodal spread, and 40% have distant spread at the time of diagnosis. It has sometimes been associated with altered gene mutations, which include P53, KRAS, P16, INK4A, and ERBB2 HER2, and adenomas, which have a high prevalence of beta catenin mutations. Now, how gallbladder cancer spreads. So, the draining nodal basin includes hepatoduodenal ligament, which goes to periaortic nodes near celiac axis or pancreaticoduodenal nodes down superior mesenteric arteries. It may sometimes spread directly to the liver through segment 4 and 5, bile duct, duodenum, colon, and kidney. It may also spread via perineural region, or there could be transperitoneal spread as well. Coming to the staging, see, as we had discussed before, that the layers of the gallbladder helps us in the staging of gallbladder carcinoma. So there is TX, where primary tumor cannot be assessed, T0, new evidence of primary tumor, TIS, carcinoma in situ, T1, which is further subdivided into T1A and T1B. T1A is tumor if it invades lamina propria, which was the inner layer, and T1B if it invades the muscle layer. T2 if it invades perimuscular connective tissue, but there is no extension beyond serosa or into the liver. T3 if it invades or if it perforates serosa or directly invades liver or any of the adjacent organ, which includes stomach, duodenum, colon, pancreas, omentum, and extrahepatic bile ducts. T4 if it invades main portal vein, hepatic artery, or it invades two or more extrahepatic organs or structures. NX is no regional lymph nodes cannot be assessed. N0 is no regional involvement, and N1 is regional lymph node metastasis. Coming to the M staging, M0 no distinct metastasis, and M1 is distant metastasis. If we come into the stage grouping, so stage 1, which includes 1A and 1B. So T1, T2 with N0 and M0. Similarly, 2A, it's T3, N0, M0. Stage 2B, T1, T2, T3 with N1. Stage 3 is T4, NEN, and stage 4 is M1, NED, NEN. So, how we will come to the diagnosis? First, we'll get routine parameters like CBC, LFT, RFT, coagulation profile. We will consider with baseline serum CEA and CA 19.9, which help us to know about the prognosis as well as how accurate the treatment we are able to provide it. Ultrasound or CEC and or CCT abdomen and ultrasound guided FNAC from GB mass. And we should consider staging laparoscopy, especially for greater or equal to T3 tumors poorly differentiated or positive margin on cholecystectomy. Coming to the treatment, if it is a localized disease, if we are able to grasp it at early stage, surgery is the main line of treatment, which includes complete resection with negative margin remains the only curative treatment. Followed surgery if the diagnosis comes as T1A with negative cystic duct margin. So no further therapy is required. If it comes T1A with positive cystic duct margin, we should go ahead with resection of cystic duct or CBD to negative margin. Radical or extended cholecystectomy, if it is being done, which is being recommended for T1B, T2, or T3 with localized hepatic invasion or limited regional node involvement. If incidental finding cholecystectomy, and if it has come as PT1A and if a negative margin is there, we can go ahead with observation. And if there is an incidental finding on cholecystectomy, which is T1B or greater, and if it is resectable, Lymphadenectomy with hepatic resection plus minus bile duct excision to obtain clear margin, which is generally a completion surgery. Coming to the adjuvant therapy. So adjuvant therapy includes chemotherapy, which is usually a combination of gemcitabine and cisplatin based regimen, which improves survival compared to single agent chemo for locally advanced and metastatic disease. And role of chemoradiotherapy is uncertain but generally recommended for T2N1 or T3 T4 disease with positive margin or residual disease during surgery. So, few of the various systemic regimens which we follow during neoadjuvant and adjuvant setting. So, in neoadjuvant, first line is Folfox or capecitabine with oxaliplatin, gemcitabine with capecitabine, or gemcitabine with cisplatin. Now, other immunotherapies like durvalumab with gemcitabine or cisplatin, or gemcitabine with cisplatin plus paclitaxel. And in adjuvant settings, we follow more or less the same regimen, but in that single agent, capecitabine is preferred, followed by Folfox, capecitabine with oxaliplatin, gemcitabine with capecitabine. If there is an unresectable advanced disease where we can go ahead only with the palliation, so in such patients, we can go ahead with biliary drainage because these patients generally present with jaundice, loss of appetite, fever, abdominal distension. So this might help the patient in the symptoms control. If the patient general condition is fair, we can go ahead with gemcitabine based chemotherapy if KPS allow us. Otherwise, best supportive care along with the prognosis of the disease should be done and symptomatic management which includes pain control, nutrition support. Sometimes the pain is unbearable, we can go ahead with palliative radiotherapy. So, systemic therapy guidelines for unresectable and metastatic disease is preferred, which is gemcitabine plus capecitabine and durvalumab. And other recommendations that we have discussed is gemcisplatin, Folfox, capecitabine with oxaliplatin, gemcitabine with pacli or capecitabine. Sometimes targeted therapy, which are also being under investigation, can be used in gallbladder carcinomas. So this biliary drainage in this from outside the catheter is being passed to the gallbladder, and then the catheter is being passed, and the drainage bag which is being put forward outside, which patient have to carry, which is called as the PTVT, but it is painful plus it is socially unacceptable to the patient. Coming to the survival, which is according to the stage wise, so if the patient present to us in stage 1, there is 50% 5-year overall survival. If it comes in stage 2, then for 5-year survival is around 29%, which drastically decreased. In stage 3, it is 14%, and stage 4 is only 20% 5-year survival. If we look ahead with the grading, so well and moderately differentiated, the median specific survival time is 69 months, and if it is poor grade, then it is only 28 months. Thank you.